Welcome to this video on how to manage a bleeding patient at Randwick campus. When a patient is bleeding, usually there are senior team members present, but it is still important for everyone to understand what critical bleeding means and what they can do to ensure patients receive care as soon as possible. Often these situations develop very fast and your help can be life-saving. Remember that depending on the situation, there are emergency protocols in place for hemorrhage, including in trauma and obstetric patients. It is important that we are aware of and follow these guidelines. At Randwick campus, we use the critical bleeding protocol. Some of you may be familiar with other terms, including the term massive transfusion protocol, or MTP. The first thing to remember is that at Prince of Wales, you cannot call an MTP. You must call a critical bleeding protocol. It is also important to understand that when your patient is bleeding, they are losing red blood cells, but they are also losing other elements of their blood that help their blood clot. Treating critical bleeding requires replacement of red blood cells with packed red blood cells, but it also requires replacement of other blood factors to allow the patient's coagulation system to work. This can include platelets, plasma, and cryoprecipitate. We can call these other elements yellow products. Before we delve too deep into the protocol, in order to reduce bleeding, there are some physiological targets that we really should prioritise early in order to ensure optimum function of the coagulation system. By virtue of having activated the CBP, we should be preparing for infusion of large volumes. Be proactive in maintaining normal temperature and calcium, and as best as possible, prevent acidosis. So let's go through what critical bleeding means and how you can determine if your patient is experiencing critical bleeding. To qualify as critical bleeding, the patient must be unstable from blood loss and be expected to need more than 4 units of blood in 4 hours. This may be because of significant trauma, major GIT bleeding, or surgical or obstetric bleeding. Once a senior clinician decides that a patient is having critical bleeding, there are several things we need to do. 1. We need to collect a set of baseline bloods. Remember to collect from a site without an infusion running, or if you have no other option, to pause infusions for 3 to 5 minutes first. 2. We need to tell the blood bank so they can get blood as quickly as possible. Blood bank can be contacted on 29145 and you must say, I need to activate the critical bleeding protocol. Remember, you can't ask for an MTP. You will also be asked if you want a non-ROTEM or ROTEM guided protocol. ROTEM is a testing device that gives us more accurate information about how blood is clotting. We can use it to determine which of the yellow products are most needed rather than giving the standard set. If there is critical bleeding and the patient is unstable and there are no staff available to run a ROTEM, then we use the non-ROTEM protocol. ROTEM guided protocols require a member of staff to run testing and a patient who is able to tolerate resuscitation with crystalloid and red cells only while waiting to determine which yellow products, if any, are required. When you activate the critical bleeding protocol, regardless of ROTEM or non-ROTEM guidance, the blood bank releases 4 units of blood for your patient. You must fill in this pink form and give it to a porter immediately so they can collect the blood form from blood bank on level 4. The form can be completed by nursing staff and a new form is needed each time you send for any blood product. As you can see, the protocol has 2 different arms. If you choose the non-ROTEM arm, you rotate between pack 1 and pack 2 until bleeding is controlled. The contents of these packs are standardised. In the first, you get 4 units of packed red blood cells, 4 units of extended life plasma, a longer shelf form of FFP, and 3 units of apheresed cryoprecipitate. In the second pack, you get another 4 units of packed red blood cells, 4 further units of extended life plasma, and a bag of platelets. You can also consider giving tranexamic acid for any patients with clinically significant bleeding. This has been shown to be particularly helpful in trauma and obstetric hemorrhage. Now let's quickly talk about what ROTEM guided means. Don't worry if this is new information for you. Randwick was actually one of the first centres to start using the new cartridge-based ROTEM, so it's understandable if you've never come across it before. Most clinical bleeding scenarios on campus are managed using ROTEM guidance, as long as there is a team member, usually from anaesthetics or ICU, who is ROTEM trained. If there is no one able to assist with the ROTEM guidance, as may happen in the ward or emergency, then the critical bleeding protocol Pack 1 of products should be requested by asking for non-ROTEM critical bleeding protocol and administered while awaiting ICU assistance. This is a picture of a ROTEM machine. There are 4 ROTEM machines on Randwick campus, 2 on level 1 in the main operating theatre of Prince of Wales and the operating theatre of the Royal Hospital for Women. The other 2 are on level 3 in the Cardiothoracic Operating Theatre and the Cardiothoracic ICU. Public hospital emergency ROTEMs should be taken to level 1 main theatre or women's operating theatre machines. Unlike usual coagulation tests, which have to be sent to the lab, ROTEM is a point of care test that is usually run by nursing staff. To run the test, they need a citrate tube, which is the blue cap tube that you usually use for coagulation tests. Results are back quickly, usually in 10 minutes. The labelled blue top tube can be taken by a resident or porter to level 1 theatres. It's a good idea to call first on 20500 for Prince of Wales or 26856 for the Women's Hospital, so that a nurse can be ready to assist to run the test. Be sure that there is a plan on how the results will be returned to the location required. This is a graph the machine produces. It is a representation of the patient's ability to form a clot and shows the time for the clot to start forming, which is called the CT or clotting time. We can also measure the strength of the clot, which is determined by the amplitude of the curve, or how fat the curve gets. This is measured in millimetres, and we use the A5 or amplitude at 5 minutes. We can also look for an unstable clot by looking for how quickly the clot breaks down over 30 minutes. The 4 squares are different measures of aspects of the coagulation system. Products are added to blood by the machine so that we can look at these different aspects. XTEM is a measure of the extrinsic clotting system and can be thought of as similar to INR. INTEM is a measure of the intrinsic clotting system and can be thought of as similar to APTT. FibTEM tells us about fibrinogen levels and is similar to a fibrinogen count. HepTEM is usually only used in cardiac cases and removes heparin to give information for patients who have been given large doses of heparin for cardiac bypass. When you use ROTEM to guide your critical bleeding protocol, the information taken from the graphs on the previous slide is used to determine which blood products are needed. Next to the ROTEM machine is a sticker that you can see on the left. The nurses will fill this sticker in with the numbers taken from the graphs. The relevant green, orange and red ranges should be chosen and circled, giving immediate visual feedback if there is a result in the red range. This is the Prince of Wales and Royal Hospital for Women algorithm. The numbers on the sticker are then compared to the algorithm to determine which products are needed. The protocol has been designed as a traffic light system, where red means something definitely needs fixing and green means there is normal coagulation. We usually do not treat results in the orange range, as they are considered adequate for hemostasis. When you have significant bleeding and coagulation is in the green or orange range, it usually suggests that you need surgical intervention to stop the bleeding. For each step in the algorithm, we use the number on the sticker to determine if there is a problem with that part of the coagulation system. A key aspect of the design of the algorithm is that if there is a problem, you should stop and fix it with the appropriate treatment and then retest. You may frequently find that correction of issues identified early in the algorithm will improve parameters further down the line. In other words, don't look down the pathway and correct multiple factors at once. Importantly, the sticker must always be completed and placed in the patient's notes with your management plan included. Be aware that there are different algorithms for patients post-cardiac or vascular surgery. These patients have received large doses of heparin and may require reversal with protamine. There are also different algorithms for Sydney Children's Hospital to be used in children with critical bleeding. The major difference is that the doses of the products are given in mils per kilo. Okay, so now let's use an example to show how the algorithm works. Sarah is a 25-year-old woman who's brought in by ambulance to emergency following a car accident. She is pale, drowsy, tachycardic and hypertensive. Her fast scan shows significant abdominal bleeding and she's taken to theatre where a ROTEM is performed. You can see the printout for Sarah's ROTEM in the top right corner. And from that we can see that her XTEM A5 is 21, which is below 35 in the red and hence abnormal. Her FibTEM A5 is 3, which is below 12 in the red and abnormal. And her XTEM CT is 118, which is above 90 and abnormal. Now let's look at the algorithm to see what this means we should do. Now in operating theatres, they should be addressing Sarah's physiological variables. And she's obviously demonstrated that she has significant bleeding, so we can proceed with the algorithm. The first step in the algorithm asks for the XTEM A5. If the number is less than 35, it suggests that there is hyperfibrinolysis. This can be treated with TXA if not already given. Sarah's XTEM is 21 and she's a trauma patient, so we would definitely consider giving TXA. In this case, we can then proceed with the algorithm. We then move on to the next step, which tells us that the fibrinogen is low. In many cases, especially trauma, fibrinogen is low because it's been consumed by the coagulation system. If the FibTEM A5 is less than 12, fibrinogen is low and should be replaced. The lower the number, the more fibrinogen the patient needs. In our case, Sarah's fibrinogen is 3, which is very low. Given this, we can see that she needs 12 units of cryoprecipitate to replace her lost fibrinogen. Given that we have now identified a problem, we need to stop and treat that problem. We then repeat the ROTEM after 10 minutes after we've given all the cryoprecipitate and repeat at the start of the algorithm. 10 minutes later, we repeat Sarah's ROTEM, which is shown above. As you can see, both graphs now look much thicker. Often when you fix one aspect of the coagulation system, in this case by giving fibrinogen, other measures will improve as the system works better. This is why it's important to use the algorithm in a step-like approach. Now we can see that Sarah's XTEM A5 has improved to 59 and her FibTEM A5 is 23 and her XTEM CT is 51. All of these measures are now green, indicating that Sarah's blood no longer shows signs of abnormal clotting. So to summarise, at Randwick campus we use a critical bleeding protocol, not MTP, and we need to activate it by calling 29145 and using the words critical bleeding protocol. This will facilitate 4 units of packed cells delivered to you initially to manage bleeding. Most clinical bleeding scenarios on the campus are then managed using ROTEM guidance, as long as a team member, usually from anaesthetics or ICU, is ROTEM trained. A blue top tube is taken to level 1 theatres and a nurse there can readily assist to run the test and return a sticker result by porter or phone call. If there's no one able to assist with the ROTEM guidance, as may happen in a ward emergency, then the critical bleeding protocol first pack of products should be requested by asking for non-ROTEM critical bleeding protocol. Hopefully, with the above protocol, you'll be able to manage your bleeding patient successfully. Importantly, don't forget that when your patient has stopped bleeding, you must call blood bank and stand down the critical bleeding protocol. We hope this has been helpful and you enjoy your term at Randwick campus.